Hi, thanks for coming in today. We understand that you've recently had a child diagnosed with Tetralogy of Fallot, and we'd like to do our best to explain to you a bit about the condition, how it's inherited, what changes it makes in the body, some of the treatment options, some testing, and what this might mean for you in any future pregnancies along with your current child.
So the Tetralogy of Fallot is a birth defect that affects normal blood flow through the heart. It occurs during fetal growth when the baby's heart is developing, and it occurs in about every 1 to 2,000 babies. There are 4 heart defects present at birth that will be explained a little bit later in more detail, but the 4 heart defects are a hole between the right and left ventricles, so the right and left sides, and a narrowing of the valve and artery that connects the heart with the lungs, an aorta that is shifted to the right that makes that aorta receive blood from both ventricles instead of normally it would be receiving from just the left ventricle, and a thickening of the muscle of the right ventricle. In most cases, the cause is unknown, but various factors can increase the risk of a baby being born with the condition, like a viral illness, alcoholism or poor nutrition during pregnancy, a mother older than 40, a parent who has the condition, or the baby having a syndrome, like DeGeorge syndrome, which is a disorder caused by a birth defect in chromosome 22, or Down syndrome, or trisomy, also known as trisomy 21.
So as we were saying, the Tetralogy of Fallot is a congenital heart defect, meaning that when the baby's born, the malformations in the structure of the heart are already present as they happened during development. And this condition is actually a combination of 4 interrelated heart defects. And these are a ventricular septal defect, an overriding aorta, pulmonary stenosis, and right ventricular hypertrophy. So the first defect that we'll talk about is the ventricular septal defect, which is also called a VSD. Just to give you a little bit of background about the heart, the 2 lower chambers are called the ventricles, and they have a septum that runs between them. And a VSD is a defect in this center wall of the heart that is meant to divide the lower portion into left and right sides. This wall is present to keep oxygen-rich blood from the lungs, separate from the oxygen-poor blood returning from the body. And on our diagrams here, we can see the blue side is meant to represent oxygen-poor blood that's coming back from the body. And on the red side, we have oxygen-rich blood that's coming back from the lungs. Normally, these flows are kept separate, but when there is a septal defect, it causes a hole between these chambers, and the blood's allowed to mix, so it gives us kind of this purple mixing in between. So this defect is combined with the next one we'll talk about, which is an overriding aorta. Now, the aorta is the largest artery in the body, and it carries oxygen-rich blood away from the heart to the rest of the body. You can see it in our diagram. Up at the top of the heart, it's the large red vessel that says AO on it. This artery is usually attached to the left side of the heart, so it's attached to the side that is painted red. But with this defect in the Tetralogy of Fallot, the aorta is instead positioned in the middle of the heart. And it can be a bit difficult to see on our diagram on the right-hand side, but you can see that where the blood is mixing, it's shown in purple because the VSD is allowing the mixing to occur. And the aorta is actually right above that, so it's taking this mixed blood, and that's what's being pumped to the rest of the body. So this does cause oxygen-poor blood to be sent back. There is some blood that's coming back with oxygen, but it's not as much as you would normally see. So the third defect is called pulmonary stenosis. The pulmonary artery carries blood from the heart to the lungs. And on our left-hand side of the diagram here, you can see what this looks like in a normal heart on the blue painted side. So that blue oxygen-poor blood gets pumped through the main pulmonary artery, which is abbreviated MPA on there. And this blood is sent to the lungs where it gets oxygen and then returns. But in pulmonary stenosis, the valve that controls the opening to this artery has a defect, and it causes it to both be constricted or to not open properly. So on the right-hand side, we can see that that artery is much more narrow. There's actually some thickening around the valve that causes it not to function properly. Now, this defect causes decreased blood flow to the lungs. So because of this, the heart has to work even harder to pump the same amount of blood to the lungs in order to get the same quantity of oxygen-rich blood back. So the last defect is actually more of a consequence of the other defects, and this is called right ventricular hypertrophy. So the other defects cause decreased blood flow to the lungs. So the heart has to work even harder to get this same amount of blood to the lungs. Because of this, the wall of the heart that controls blood flow to the lungs gets more muscular from increased use. And this part of the heart is called the right ventricle. And because the muscle gets more use, it thickens, it gets more muscular, and this, in effect, is called hypertrophy. So this condition can present in a variety of ways in its effects on the body. I've selected a few signs and symptoms here just so that I can demonstrate some of the more common ones, but like I said, there are a variety of different symptoms and presentations. So children with this condition usually have a higher chance of developing cyanosis of the skin, which is a bluish, purplish coloring that we see sometimes on the tips of the fingers and the extremities, and this is just evidence of the decreased oxygen supply to these parts of the body. They are also more prone to have symptoms related to low oxygen levels in the blood. These can be dizziness or fainting spells. You also see an increased risk for heart infections due to the mixing of the blood. Children also can present with delayed development because of the poor oxygen in the blood, and they can have heart murmurs due to the differently shaped valves and connections. So the mode of inheritance for this condition is a bit complicated. As was mentioned before, sometimes this can be caused by genetic factors. And genes are like the instruction manual for our body. And if genes are disrupted or changed, then it can change how the body develops, how it functions, and can sometimes lead to disease. So we have identified 7 different gene mutations that can be related to this condition. And all of these genes present in an autosomal dominant pattern to the best that we know. And a child only needs to inherit one copy of this altered gene from either parent to be at risk for developing the condition. So if, for instance, one of the parents carries one of these mutations, then you have a 50% chance of passing on the mutation to a child. So with this condition, we do see what is called reduced penetrance. And this means that not everyone who has the gene alteration necessarily develops the condition. So many of the genes, in fact, of the 7 different mutations, many of them show reduced penetrance, meaning that individuals are not guaranteed to develop the condition if they inherit the mutation. And as was mentioned before, this condition is affected by both genes and the environment. In fact, in many cases, we don't know exactly what causes it at all. Because it's affected by genes and the environment, we call this mode of inheritance multifactorial because these factors interweave and combine with each other.
So the heritability for Tetralogy of Fallot is about 54%. So if there is an autosomal dominant mutation, then there is a 50% chance of passing it to a child if one parent is affected. But since most of the time it is a combination of genes and other risk factors, the risk of recurrence is actually a lot lower, and it's about 2.5 to 3% for first-degree relatives of an affected child. So about 3 out of 100 parents who have a child with Tetralogy of Fallot will also have another child with the condition. But that also means that 97 out of 100 parents who had a child with the condition will not have another child with the condition.
Okay, so now we're going to move on to treatment. Really, the only available treatment for Tetralogy of Fallot is surgery. There are two different types of surgery. One is an intracardiac repair, and the other one is getting a shunt. Most children born with Tetralogy of Fallot get intracardiac repair. If you do get a shunt put in, that's only a temporary fix, so you will eventually have to have that intracardiac repair surgery. After having the initial surgery, many people will need to have more surgery later in their lives. The most common reason to get surgery is to have the pulmonary valve replaced in the heart. So because of this, it's very important that after the patient has the intracardiac repair, that they do have a pediatric cardiologist that follows them throughout their life. And then once they move into an adulthood, an adult cardiologist, because we really want to monitor the heart regularly. And if there are any problems, we want to catch them early and have a cardiologist determine what is the appropriate time to get any additional surgery. Okay, so the main surgery is the intracardiac repair. This is normally done within the first year of the child's life. The first thing that happens is a patch is placed over the hole between the two lower chambers of the heart. These are also called the ventricles of the heart. The second thing that's going to happen during the surgery is that the pulmonary valve is either going to be repaired or replaced. And it's going to be widened to increase blood flow. What should happen after the surgery? The right side of the heart, normally that right side of the heart has a thicker wall than normal because it's been working harder to pump blood throughout the heart. So after the surgery, that right ventricular wall should return to a normal thickness, and also the oxygen level in the blood should increase. So the other option besides an intracardiac repair is to have temporary surgery. Sometimes when babies are born with Tetralogy of Fallot, they do have to have a temporary surgery before they go through the actual repair, and that helps to increase the blood flow to the lungs before they go into surgery. So temporary surgery, what happens is the surgeon creates a bypass, which is called a shunt, between a large artery in the heart and the pulmonary artery. And when the baby's ready to go in for the main surgery, the surgeon will take that shunt out and actually repair the heart. So Tetralogy of Fallot can be detected during an ultrasound, and if when you have an ultrasound, the heart defect is detected, what will happen is you will be referred to have a fetal echocardiogram, which is when the heart of the fetus specifically has an ultrasound done on it, and that will confirm the diagnosis before the birth of the baby. Around 50% of children with Tetralogy of Fallot are diagnosed prenatally, so they're diagnosed before the baby is born. Okay, so that is the end of our presentation on Tetralogy of Fallot. I'm going to go into quickly a couple of difficulties that we faced while doing this presentation. So the first one was that it was difficult to figure out what terms and how much detail we should go into for this presentation. We knew that this should be geared to a family that had just figured out that their child had been diagnosed with this heart defect. And we also knew that it was going to be one of their first encounters with this material. So it was a little difficult just deciding, what terms would be most understandable, and how much detail was appropriate to go into for different parts of the heart defect. The next challenge that we had was finding consistent information about the inheritance of Tetralogy of Fallot. So there were a couple discrepancies about how exactly the defect was inherited. So we kind of consulted with each other and analyzed different sources about what was the correct inheritance. And then lastly, just difficulty coordinating each other to work on this project and really when we were going to record the slides. For example, I knew that I went out of town earlier this week. I know Kara traveled this weekend. So just coordinating schedules to figure out when we were going to record the slides for this presentation.